Well, Deb, thanks so much for the invitation and thanks for that warm introduction. I hope I live up to it today, but it's a pleasure to be with you. I'm based in Charlotte, North Carolina, so it's a pleasure to connect with you today over Zoom. I'll go ahead and share my screen again. Okay, so today I'll share a little bit about some of our work advancing equitable outcomes in the academic learning health system. And I have a brief agenda for us today. I'll start with a personal story just to let you know where I come from and where some of my passion for this work emanates. I'll talk a little bit about where I work currently in a learning health system with a for all mission. And then I'll discuss some of the research that we've been doing here and conclude with some closing thoughts and opportunity for Q&A. So I'll start with a personal story. I'm from Liberia. I grew up in Monrovia. Liberia is located in West Africa, for those of you who may not be familiar. The pictures on the left are from my last visit there, which was 2009. It's been a while since I've been back home. But we had the opportunity in 2009 to celebrate a holiday party with some local kids in the community. I really enjoyed that experience. For those of you who are not familiar with Liberia, we have a population right now of about 5.5 million. So that's half the size of North Carolina, where I live. About 50% of the population lives below poverty, according to recent statistics, and then less than half of adults are literate. And then we also have a very high infant mortality rate, several health conditions. But as you can see from this picture, and one of the things that I've tried to do in my research, especially with marginalized populations, is sort of think about, despite all the statistics, what are the strengths within those communities and how we can, as researchers, partner with communities to build on those strengths to improve health outcomes. So a little bit of my journey since leaving Liberia. I attended undergrad at Shaw University in Raleigh, North Carolina. Shaw is a historically Black college university and one of the first four-year medical schools for Blacks in the United States. I did my undergrad there, and actually after that went to North Carolina State University and studied statistics. Came back to Shaw and worked for a while in a research institute that they had there that was focused on examining health disparities across different populations and different health conditions. And then I went back to school where I met Deb at UNC Charlotte and did my PhD in health services research. And there I grew an interest in a focus on maternal child health specifically and looking at social determinants of health related to that. When I was younger, growing up in Liberia, I thought I was going to be a doctor, thought I was going to be a pediatrician, but I've had the opportunity, to continue to focus on maternal child health as part of my research program. And so while I was at North Carolina, the University of North Carolina, Charlotte, I started working at Atrium Health. At that time, it was called Carolina's healthcare system. And we've been there almost a little over 14 years. It will be 15 in January. And have had a great experience conducting research in the real world setting of a healthcare system. We'll talk a little bit more about what that looks like and the opportunities that we have to really transform care and make an impact on patients' lives. So I'll dive into a little bit about our healthcare system. And as you may have observed from Deb's intro, that we are an evolving health system. When I started, we were Carolina's healthcare system and then Atrium Health. And about 3 years ago, we merged with Advocate Aurora Health, and we're now Advocate Health. So that spans the four institutions that you see on your screen, but we're all tied together by our purpose statement, which is from discovery to everyday moments, we're redefining care for you, for us, for all. So our health system really has for all in its mission. And, whether it's research or patient care, really trying to focus on the goals of improving health outcomes for everyone that enters through our goals. And so just a few slides to orient you to this idea of an academic learning health system. And you may have heard the term learning health system before. Wake Forest actually led some work in sort of defining what an academic learning health system is as part of its integration with what was then Atrium Health. And the definition that Wake Forest University uses is academic learning health system is grounded in the idea that combining care, research, and medical education creates synergies that leads to better health, accelerates innovations, and provides a richer learning experience to cultivate tomorrow's healthcare leaders. And it's a really exciting environment here to conduct this kind of research. And we actually just earlier this year launched Charlotte's first four-year medical school where students will get to work closely with healthcare providers, innovators, advanced technologies to learn how to deliver medical care, but also very closely connected with community so that the community focus is central in their learning and hopefully in their future practice. So some colleagues and I actually wrote a paper shortly around the time Atrium and Wake Forest University were merging, and we took a stab at sort of describing our own personal experience with developing a learning health system at Atrium Health. And some of the things that we highlighted in that work included, how you create a learning culture, how you develop partnerships, focus on bi-directional communication, how the learning health system requires investment, and then also how it requires pragmatic mixed methods design to understand real world outcomes. And the reason I cover these topics is because the context in which we conduct the research it really informs how we do research, what we research, and what the outcomes of those research studies are. So in this paper, we talked about our experience with some of these concepts, but also to what are some of the things we were able to accomplish in areas like antibiotic stewardship, sepsis, which is a huge issue within the health system in terms of patient outcomes and many applications. So with that, I'll bring you to a brief introduction of the center that I currently co-direct, which is the Center for Health System Sciences. And the mission of our center is to improve healthcare delivery for all, again, through iterative care transformation, evidence generation, and continuous learning. And we have a vision to enable research that transforms healthcare delivery. And so you might say, Yhenneko, what does all of that mean? So really it means that we are trying to be an engine, like the image shows, or a chassis for facilitating how we move from just questions about what works to actually using rigorous methods to actually figure out what's actually working, and then hopefully translate those findings into improvements in care for patients. And so that becomes an iterative process where we're collaborating with stakeholders, figuring out what the current challenges are, and then taking that information to design a research question, evaluating data to answer the question, and then taking it back to those stakeholders for hopefully implementation into their clinical practice. And so the two foundational pillars that informs our work at Chassis, one is the idea of health system science, which is the study of how care is delivered, how health professionals work together to deliver that care, and how the health system can improve patient care and healthcare delivery. And so the work that we do sort of spans the gamut of interventional studies, also to studies that just think about how we deliver health better or differently. So we do a lot of studies related to virtual care and telehealth. Some of that started during the pandemic, but some of that predated the pandemic and still continues. And certainly we do studies on health outcomes as well. And then, as I mentioned before, this idea of the learning health system. So a learning health system being one, this is the IOM definition, where the science, informatics, incentives, and culture are aligned for continuous improvement and innovation. And then the second piece is also very important, and why having researchers like myself and my team really embedded within the health system helps, because then you can take those findings and collaborate with the relevant stakeholders to embed those findings into how care is delivered in the future. And then my final slide is about our centers, this one, and just demonstrating how within our larger health system of Advocate Health, how we're looking to uh, connect research questions to various aspects of our academic core, as well as the health system operation side. So our project teams tend to be very multidisciplinary with, folks from all aspects of our organization, really with the focus of investigating healthcare delivery challenges, testing ways to address those challenges, and facilitating that translation of those findings into everyday practice. So with that, I'll just transition a little bit into thinking about, we have these goals around improving care for all. We have goals around equitable outcomes. And how do we get there? I think the first step is really to understand the factors that are impacting health. And one of the groups that we work closely with here at Chassis is our community health group. And many of you may be familiar with this figure, which comes up a lot when you're talking about community health, is what are the factors that are really impacting health outcomes? And this figure from UCLA Health mirrors one that's you may find in other venues, but really talking about, about half of our health outcomes are related to things outside of health behaviors or the healthcare we receive. So the World Health Organization defines SDOH, or social determinants of health, as the conditions in which people are born, grow, work, live, and age, and also the wider set of forces and systems that shape the conditions of their daily life. So as a research team thinking about how do we accomplish this goal of improving health for all, we really have to think about what are the factors that are impacting health outcomes, and make sure that our research is covering, all of these factors. So not just thinking about healthcare access, but also some of the underlying factors that impact health outcomes. And this figure from Health Resources in Action covers this in a slightly different way. And it really describes how health inequities are the result of systemic factors that influence health behaviors and outcomes. So you can see sort of in the roots of this tree on your right that you have systems and culture that then informs the social determinants of health that include employment, housing, social environment, education, violence, etc., that subsequently influence health behaviors like stress, exercise, diet, smoking, and then further influence the health outcomes that we see: cancer, hypertension, diabetes, etc. So having sort of a holistic view of, these factors that influence health then allows us to conduct research in a way that's not only considering sort of the visible outcomes, but some of those more structural factors that impact how members of our patient population experience health in their daily lives. So again, as we think about, how do we accomplish this goal of improving health for all, we have to think about who we're actually serving. And this photo on your right is from the US Census Bureau, and just showing projections. This figure may be a little bit dated, but showing projections to 2050 on the US population. And you can see that this figure suggests that, by 2050, our population will look very different than what it looked like in 2010, with a higher population of Hispanics, a higher population of, in a lower population of non-Hispanic whites, and then with our Black non-Hispanic population also growing into 2050. And so what does that mean? Probably not much with this specific figure, but if you think about how the resources and factors that influence health are distributed across these populations, then you know that as the population changes over these next several decades, if we do not address the factors that are influencing disparities in health today, those inequities will just be more pronounced in the years to come. Also wanted to talk a little bit, most of my work does focus on racial ethnic differences in health outcomes, but I think it's also important to focus on geographic differences. And I showed you before that our health system is growing now with locations in 6 states in the US, both in the Southeast where I am, as well as the Midwest. And so understanding the geographic disparities that exist within US are also quite important. This figure on your screen is life expectancy at birth. And you can see how, the Southeast where I am, we have much lower life expectancy, and the legend at the top of the screen shows you that, the dark red are much lower, and then the blues are a much higher life expectancy. So you can see even within our health system, so for our sites in the Southeast, much, much lower life expectancy than some of our sites in the Midwest. And so certainly something we have to keep in mind as we think about strategies for addressing differences in health. And just one more statistic for you, again, showing life expectancy in years by race, ethnicity. You can see that for Blacks, far to the left in terms of life expectancy decreasing for all groups, but certainly much more significantly lower for the Black population. And I'll close this section talking about our organization with this quote from our CEO, who had the opportunity to present in front of the Senate Committee on Health, Education, and Labor in 2021 during the COVID pandemic. But one of the questions he asked was, what does it look like for the next iteration? What does the next iteration of For All look like, and how can we play a role in eliminating health disparities completely? So this is certainly something that he's passionate about, and something that provides sort of a framework for some of the work that we do here, investigating disparities that exist and figuring out strategies for addressing those. So with my next several slides, I'll move into just some example research studies that we've conducted here, my team and I, across 3 areas that I'm involved in: diabetes, hypertension, and infant mortality. And we'll be talking about just some of the work that we've done, our findings, and opportunities for future work. So the first topic, this was one of the first areas that I worked in when I joined this team, but over the course of 6 years or so, this was a period from 2014 to 2020 when our health system had a focus on improving outcomes related to diabetes. So our team tends to focus on health system priorities, and diabetes control, blood sugar control is one of the priorities during this period. And so during this period, we conducted several studies looking at differences in outcomes and trying to identify what are the factors that are driving these differences and how can we improve care. So we conducted some retrospective research looking at ED visits and healthcare utilization. We also did some work with residents trying to understand their awareness of health disparities and their preparedness to address those. And then we did some work looking at, we also did some work looking at quality metrics and seeing how we were doing across those. And I'll talk through those results briefly here. In this study, this first study that I'll share on, we looked at healthcare utilization by race, ethnicity, but also by diabetes control. And so the question we're trying to answer here was, does healthcare use vary by race among patients with controlled and uncontrolled A1C? And in this retrospective study of over 12,000 adults with type 2 diabetes, this was from 2012, we found significant differences in healthcare utilization And they did not cluster by blood sugar control, they clustered by race. So for Black patients, regardless of whether they were controlled or uncontrolled, we found that they used the emergency department more, and that they used doctor's office visits less compared to white patients. And then in the other group, which encompasses various other ethnicities that were smaller in our patient population, those groups had lower ED visits than Blacks as well, and also slightly lower physician office visits. And so what we concluded from that work were, we identified a need for strategies such as patient education and thinking about the challenges that patients face with access and care and how we could offer different options to healthcare access to reduce some of these differences. The second study we did that I'll highlight today for you is one we did looking at our quality metrics. And so this was a retrospective study that we did looking at outcomes for over 62,000 adults with type 1 or type 2 diabetes in 2013. And we were really looking to answer the question of whether or not diabetes care and outcomes vary by race ethnicity. And what we saw here, interestingly, in our patient population, we did not find significant disparities by quality measures. So we looked at annual A1C tests, annual blood pressure checks, annual foot exams, and you can see the teal bars are those who identify as Black, the black bars are those who identify as white, and then red, Hispanic, and orange, other race. And so in this analysis, we did not see significant differences by race or ethnicity. However, when we looked at outcomes, so whether or not blood sugar was controlled, whether or not low-dose lipoproteins were in the acceptable range, and whether or not blood pressure was controlled, we did find that there were significant differences. So, for example, in A1C control, Black patients had only 17% were meeting that. Or we had 17% that were exceeding the goal for control. So basically, 17% not having their blood sugar controlled compared to 10% of our white population. And so our conclusions from that work was that there was a need to strengthen partnerships between patients and their clinical teams, certainly an opportunity to increase self-management support and utilize shared decision-making to help improve some of these outcomes. So overall, what we found in this research was maybe some of our processes of care weren't significantly different, but again, potentially research that's pointing to those social determinants. So thinking about things outside of the care setting that may be influencing how those patients may be experiencing their health. And I believe this is the final study on diabetes that I'll present, but this was research that we did with residents. And actually, this was research that we did with Black and white patients, looking at their experiences with care. And so this was a qualitative study where we're really trying to understand what are the barriers that patients are facing and how do they perceive their care. And the overall conclusion from this work was that patients really valued the relationships that they had with their providers. There weren't really many differences in terms of what our Black patients wanted or our white patients wanted from their providers. They value consistent relationships. They felt like it was important to have a good relationship with their doctors. They felt like their provider communication was good. What the key insight for us from this research was that, all of our patients pretty much want the same thing, but research certainly shows that all patients may not be getting the same care. And so identifying where those patient values are not aligning with their experiences was highlighted as an opportunity to improve outcomes for this population. So we used all of these findings to sort of put together a framework for how we need to reduce these differences in care. And that framework covered 4 domains: patient, provider, health system, and community. In the patient domain, things like self-management support and culturally tailored interventions. In the provider domain, information on disparities, making sure that providers have access to shared decision-making and similar tools. In the health system domain, multidisciplinary teams to help address chronic conditions. And then in the community domain, access to healthcare, access to healthy food. And so while we've been working with our stakeholders to sort of gain traction on this specific model, we did have the opportunity to expand this model to another chronic condition, which is hypertension. And this slide shows results from a paper by my colleague Rohan Mahabaleshwarkar, who led a study looking at our patient population with hypertension. And so in this work, we looked at who has uncontrolled hypertension, what are the differences, what are the factors that are influencing hypertension, and across over 200,000 patients with hypertension. We found, again, the same story: significant differences by race. So Black patients were more likely to have uncontrolled hypertension than others. And then we also found factors like insurance was influencing uncontrolled hypertension, and then certainly those with doctor visits were less likely to have uncontrolled hypertension, and then those who did not have a primary care provider were more likely to have uncontrolled hypertension. And so this work, further solidified our prior ideas regarding diabetes in terms of the need for targeting to groups that have persistently uncontrolled hypertension, and thinking about different outreach strategies. And we are doing this work now. So we have a multi-site study called Rhythm BP that is incorporating some of these elements of targeting. So this is a study focused specifically on Black patients with hypertension. We are using team-based care. So we have a pharmacist and community health worker that are supporting patients. So we're testing two interventions. And then we're also addressing some of those social needs. So the community health worker works closely with the pharmacist, with the patient, and with the primary care provider to identify social needs that the patient has and connect them with resources. So we're in our second year of this project, and we're looking forward to seeing the results and hopefully finding out how this program addresses differences in outcomes for Black patients. And Deb, I hope I'm doing good on time. Okay. And so the final area that I just wanted to highlight is some of the work that we've been doing in the field of infant health and maternal child health. So this was a more community engaged project that we worked on with a stakeholder group of over 28 stakeholders. And so the goals of this project was really to convene various stakeholders to identify what were the gaps in care for improving infant health. And this work was funded by Smart Start of Mecklenburg County. And so through that convening, we had interviews, we had several stakeholder meetings to prioritize a recommendation across 5 domains for improvement. And this was one of the outcomes of that project, where we collaborated with our stakeholders and used interviews to develop a journey map of the experience of mothers in our community. And so that map, so we started with the preconception phase all the way to childcare, and we're able to sort of map out what some of those opportunities were for care improvements in this population. So this was one of the projects that we worked on in this domain, and this work eventually led to some prioritized areas for improvement in terms of where to access care, care delivery models, linkages to community, and some of these themes, follow through from our work on diabetes and hypertension. So certainly, sort of figuring out where are those community resources, again, pointing to the priority of social determinants of health and figuring out ways to address them. And then finally, the work that we did earlier then led to this resource that we collaborated with our stakeholders to design, which we're calling the Mecklenburg Birthing Connections website, which is a place that we've now, similar to the journey map, have mapped out resources across the perinatal continuum from before pregnancy all the way to after pregnancy. And if someone navigates to this page, they can see information across all of these domains. And we have a paper under review. The preprint is online, but really the title of the paper, Health System Community Partnership to Design an Online Resource to Address Perinatal Information Needs for Black Families. So certainly a mix of research that we have the opportunity to do here. So with that, I will transition to just a few closing thoughts and then to your questions. I really like this slide from the Robert Wood Johnson Foundation, but they describe health equity as being achieved when everyone has a fair and just opportunity to be as healthy as possible. And they've outlined some areas that are important in sort of achieving this goal. So a mission to improve health and well-being, being systematic about eliminating discrimination and focusing on justice and equity, serving the community as engaged and proactive partner. And so that's certainly something that I enjoy doing in my work, the opportunity to partner with community members, both health system stakeholders as well as externally. And often leveraging some of the existing networks that our health system has established within our broader community. Trust comes up very often in this work. Earn and sustain trusting relationships, not only with patients, research participants, community partners. The work that we are doing right now in the Rhythm BP study, I was just discussing with our advisory board co-chairs about the importance of thinking about how do you bring into research participation people who may not usually be research participants. And so that's certainly something that's front and center for our team. And then power, how do you share and effectively use resources, influence, and power? And so another area that we're continuing to work on for our Rhythm BP project, we have an advisory board made up of patients, advocacy groups, and other stakeholders that we consult with regularly in terms of how to conduct the research, what research questions matter, how we implement the study, how we share findings, et cetera. And they are integral partners with us in conducting this work. So I'll close with this quote from Dorothy Height, who was a civil rights activist. And she said, "I want to be remembered as someone who used herself and anything she could touch to work for justice and freedom. I want to be remembered as one who tried." So we started this talk with just a high-level overview of our For All mission here at Advocate Health. We talked a little bit about goals for improved health for all. We talked about some of those factors that impact health, and some of them are not easy to address. But I do like this quote because she talks about being one who tried. And I do think that even though we may not be able to answer all the questions or address all the issues that lead to disparate outcomes for communities, we can at least try. And so with that, I will pause for your questions. Thank you so much.
Thank you, Dr. Taylor. We have a couple of questions from Dr. Allgood. Leanne, would you want to pose the question yourself?
Oh, sure. Thank you. Um, First of all, thank you for such a great presentation, and I'm glad that you and Deb got to know each other so that we can hear from you today. Um, so my first question, you actually touched on a very little bit in the last quote that you shared with us. So when I, think about social determinants of health and how important it is for us to know about those heavy contributions to health outcomes for patients, that feels like a good thing. But it also feels exceedingly overwhelming. Like, how can it be possible for you to move, for us to move the needle in a way that's meaningful when there are so many things on that list that you cannot control? So just curious, like, how do you wrestle with that? How do you wrestle with that? Maybe you, as you just said, maybe you just try, you just do what you can.
Yeah, and thanks so much for that question, Leanne. And I would agree with what you just said is trying and a term that we commonly use here is don't try to boil the ocean. So thinking about that specific aspect where you can make a difference. So, for example, with the work that we're doing in Rhythm BP, obviously there are so many factors that impact hypertension control. And one of the things that came up amongst our team as we're planning that project is that, you know, access to medication is something that's really driving some of these poor hypertension outcomes. So even if you do everything else and the patient doesn't have access to medication, they won't be able to get their blood pressure under control. Well, we included that in our first grant application, and the reviewer said, well, access to medication is not sustainable. So, and so when we revised our application that was eventually funded, we excluded that. We do have, of course, some of these government programs are under scrutiny right now, but programs like 340B, et cetera. We did reference other resources that patients could access to address medication, but unfortunately, that was not something that our project was specifically designed to address. Now, we do have community health workers who can refer patients in our intervention arm to community resources, but that was not something we were able to address. What we do hope with that specific project is that we provide evidence for a strategy that can be used, that can be replicated by health systems for how you can think, how you can address the specific needs of the population. What we're doing remote blood pressure monitoring in that study is not unique to Black patients. Anybody can get remote blood pressure monitoring. Our community health workers are from the community, so they provide that additional social support and navigation. And so we're hopeful, we're just 2 years in, we won't see the results for a while, but we're hopeful that there will be some benefit in terms of adding that piece. So while we weren't able to address all the needs, we're hoping to, I guess for us, the main thing is that we're addressing the access to care, so patients don't have to come into the clinic to get help with their blood pressure because we're using telehealth. And then we're addressing connections to resources. But if the community does not have those resources, if the community does not have housing, those are certainly barriers, but we're making an attempt to at least bridge the how do I get here? Where do I go? We're addressing some of that.
I have another question, but I don't want to monopolize the question. So I will let Dr. Roy or someone get to the next question.
Thanks, Ian. Hopefully we'll have time for the second question as well. But Dr. Freeman has a question. He said that you referenced research related to determinants of health. In the late 1970s, Bloom's research revealed that 10% of total health outcomes was result of health systems access. While in the US, 90% of total healthcare costs were expended towards those health systems for the provision of care. Would you know if the imbalance persists?
Thank you for that question, Dr. Freeman. And I don't know specifically, I don't have the numbers on whether that imbalance persists, but that imbalance, I think, reflects what we see in other areas. One of the slides that I had used in another presentation talks about the US health expenditure versus other systems. And so you can see where other health systems put more emphasis on social services. And so because we're spending more money on healthcare, but we don't have better health than other countries. So while I don't know the specific numbers in terms of how much we spend on healthcare versus other things, I do believe that we still are imbalanced compared to other developed countries, where we're spending more on the health system and less on some of these social needs.
So we have time for Leanne's second question. Do you plan to measure, act, or similar, and use these findings to inform the care in your own system?
Just ask it, Deb.
Yes. And is health equity research impactful in only local settings, or is there ways that we can impact very broader national populations?
Yeah. What motivated that question is sometimes I feel like any project I do is so small, like it's not going to hardly matter outside of a very tiny local space. So how do you look at the work that you're doing within your health system? Do you feel like our goal is make equitable care and outcomes better within our health system, and other people might be able to apply it, but we're not trying to fix, the national landscape? And where do you think that work is best done? Do you think that meaningful outcomes can be changed best in those local contexts, or should they be big, broad projects that can apply, almost anywhere? Thank you.
Again, another excellent question. And I'll say that we need all of the above. And what I presented is a mix. So the work that the last few slides I presented on some of the work we did around infant mortality, that was very local. And so, we were funded by a local foundation that's focused on improving health outcomes in North Carolina and South Carolina. So that was a very local project where the goals were really to understand how we were doing in our community and what the opportunities were. But certainly, as I shared, we have a preprint for one aspect of that work that we were wanting other localities to use our findings to inform their own work as well. So that was a very local project, but we're hoping that the process that we use can inform other local groups, other localities. The Rhythm BP project that I mentioned to you, that is a multi-site study. So we have collaborators at the University of Kansas as well. And so that project and is funded by Purpose. So the goals there are definitely to result in findings that can inform more broadly. What I would say is that in my work, I've always found that two things. Number one, the challenges that our health system is facing are not unique. Those are certainly challenges that other health systems are facing. So the work that we do here, certainly, while sometimes the generalizability may be limited due to population differences, but the general concepts, processes, some of the conclusions can relate to other settings. The second thing is that as a researcher working within the health system, I've always found that it's easier to get your research done when you have buy-in from your stakeholders. So with our hypertension work right now, hypertension is a big focus of our organization. And so that's why we're doing work in hypertension. And because the goals of our project are aligned with the goals of the health system in terms of reducing or improving blood pressure control, it makes it easier for us to tell a provider, can we recruit your patient to participate in our study? It makes it easier for us to engage providers around education, referrals into the program. So, so it makes all of those subsequent steps, all of the steps you need for research easier if it's a problem that that matters to the health system. And I think I'll go a step further and also say that if it's a problem that matters to the health system, then your research becomes more impactful. Because if you're just doing it because, oh, this sounds interesting to me, and I think I can write a paper about it, yes, you may be able to write a paper about it, but then it goes nowhere because nobody's really interested in it. But if you can find a problem that really matters to real patients, real healthcare providers, then you can find a place where your findings don't just become another research paper, but that hopefully then it becomes a new program within the clinic or health system. It becomes better outcomes for patients, families, and communities.
Thank you, Yhenneko. Any other questions?
It looks like, Melinda, were you answering me or were you asking a question?
Yeah, I was responding to you. So any initiative to look at social determinants of health, even at an individual site, is impactful because if they are recorded and reported appropriately on claims data, it speaks to the larger health system as it manages both risk, population health, and cost containment. So even if you're doing a small project, big impact across the system.
Thank you.
Mhm.
Yhenneko, thank you, Melinda, for that. Melinda is with our Kirksville clinic, so just so everybody knows. I have a question, Yhenneko. Since we are a teaching school here, academic institution, does your research and findings get integrated into the curriculum at Wake Forest?
Yeah, that's a good question. So I'm not involved in a lot of teaching here. I do participate in a few of the colloquiums that we have for some graduate students that don't do a lot of teaching. But yes, when I do have those opportunities, we often have a learning health system postgraduate program, and that program does incorporate talks from researchers that go and present their work and provide those as examples. The current director of that program does what he calls lessons from the field to sort of introduce program participants to actual research that's being conducted within the health system, to sort of give them ideas of opportunities for them to conduct future research. So in that way, it is. The other thing I would say is that there are opportunities for residents and medical students to participate in research studies that we're doing here. So while it may not be part of their curriculum, they may have opportunities to work on a research study that's being conducted. We have an internship program within my center that we often have graduate students rotate through during the summer. So there's some learning opportunities for students, residents, and then we have we also have PharmD residents that rotate through some of our locations, and we're actually thinking about adding some PharmD residents to our blood pressure study that we have right now.
Thank you. Lots of things to think about that we can replicate here. Although, in my experience, Arizona is not exactly North Carolina. So there are systematic changes, systematically different. I just feel that we have a lot more obstacles than you think. You would think North Carolina is. I just feel that North Carolina is more in the health services and health systems allocation, the dollars funded, it's more progressive than some of the
Yeah.
Southwestern states.
I would encourage you to, consider a lot of the research. I've not been funded very much by the NIH. A lot of my research is foundation or other types of funding. So I would encourage you to consider the local foundations in your area that may have funding. So like Leanne was saying, it doesn't have to, and Melinda was also saying, it doesn't have to be a huge project, but you can certainly start small. So I would encourage you to look at the local foundations in your area who have an interest in health to fund your work, and then also to some professional associations also offer small grants for research funding. So don't I would say don't stop because maybe you can't get the multi-million-dollar project grant right now, but certainly look for those smaller opportunities. And even as a teaching university where the research itself could be a training opportunity for your students. So.
Any other questions for Dr. Taylor? So I believe there was more food for thought than questions. So thank you so very much, Yhenneko. And with that, this brings to the end of today's webinar, and we thank you all for joining us today. And a huge thank you to you, Dr. Taylor, for sharing your insights and expertise. As again, a reminder, this has been recorded and Dr. Taylor has kindly permitted us to upload this video on YouTube. If you have any questions, please email us. And our next session is in December, and that will be our own Dr. Adriana Silva presenting her latest dental research. I will keep you updated on that program. Thank you so very much, all of you, for joining today. And thank you, Yhenneko. Thank you so very much for taking time out of your busy schedule.
Thank
We
you.
hope to keep in touch.